Well, morning once again. PHM is a global movement for a global movement on grassroots action for health. But here in Kenya, PHM Kenya is committed to the right to health as enshrined in Article 43 of our Constitution. So we are committed to promote, defend, and protect that right. So we have members from different organizations and individuals who are part of PHM Kenya. Monday, we have the other one, Kelly, we have Ravi as an individual member. From this is still with us, and of course now we are working with local initiatives to economic, social, cultural rights. So today we are here to launch this report that was commissioned by GI-ESCR and done in urban informal settlement of Mukuru, Dandora, Mathare. So Ashila will present the findings after me. But I just want to note that as PHM we've been facing a lot of questions around government funded expansion of the private health sector, because we always believed in a stronger public health service delivery, and that approach by government, of course, has potential landmines to undermine the public service. We all know what PPPs in the health space have done. Remember the big mess. And you also remember the UFC program, how it has turned out to be. And now NHS is also playing out. So if all these reports are left unchecked,
our efforts to strengthen our public healthcare system will, for a long time, face challenges because the focus is on expanding the private health sector. And even those who are users of the private health sector, we all know we are experiencing it in different disproportionate forms. Those in low-income area experience and engage with the private healthcare service delivery differently with those in suburbs. The quality, of course, is not the same. So as a movement, we would like to reiterate that we need to work together as members of the civil society organizations to continuously counter-check these efforts that have been put in place to front profits over the greater good of delivering public healthcare service to people. I don't want to say much. I now welcome Sheila to share with us some of these findings. Thank you.
Thank you, Dan, and thank you everyone for being able to join us today for this discussion. It's a very timely, very key discussion. Thank you. So we in Kenya know that the budget was read last week, and there were significant things that came out from that regarding the budget for health. We know that there has been recently a push and pull between private sector and the National Health Insurance Fund, NHIF, about how much private sector is receiving from NHIF, and NHIF trying to make adjustments to secure more funding for public hospitals, but this facing some resistance. Like Dan has mentioned, the influx of PPPs and a push for PPPs from within the government, from government policy, but also from international donor support, where they are advising or they are financing PPP arrangements. And the intention of this report is to assess the impact of all of this private sector involvement on the right to health in Kenya, particularly in light of the COVID-19 pandemic, which we know significantly affected healthcare primarily, but also had other effects on the economy and on livelihoods, etc. So I'm going to provide an overview of the situation that was in place when the COVID pandemic hit in Kenya. And then I'll hand over to my colleague, Stella DeFalco, who is our Right to Health Officer, and she will share with us the findings and the recommendations. Thereafter, we will hear a little bit from the community members themselves, from the affected communities where the research was done, but also from other communities in Nairobi, which were not the focus of the research, but will also have an opportunity to share the similarities or differences in their context. So turning quickly to the report. So the situation in Kenya right before the pandemic and when the pandemic hit was quite dire with respect to healthcare facilities. There was a critical shortage of essential items, particularly those that were needed to address COVID-19. So for instance, we only had 256 ventilators in a population of nearly 54 million. This was around 2020, and 518 intensive care hospital beds for 100,000 inhabitants. And we know that, especially for treating COVID-19, ventilators and ICU facilities were essential. Next slide. So in terms of the share of public facilities and private facilities, the report notes that there has been a rapid increase in the share of not just private sector, but for-profit private sector. So this is businesses and commercial establishments that are in it to profit primarily. And you know that from 2013, between 2013 and 2018, the share of for-profit private providers rose from 33% to 43%, which is rapid for a period of 10 years, less than 10 years, in fact. Similarly, between 2016 and 2020, private facilities received 82% of NHIF outpatient benefits and 64% of inpatient benefits. So clearly, private facilities are receiving the lion's share of health insurance funding. This is the public health insurance that we all contribute to. Also during the COVID-19 pandemic, that's in 2021, the government entered a new PPP agreement with one of the largest Italian private healthcare groups. So we see that even in the context of the pandemic, the approach is still to work in these PPP arrangements, which have been found to be problematic in terms of ensuring access to healthcare, particularly for the most marginalized, those who aren't able to make the out-of-pocket payments, those who are vulnerable to catastrophic health expenditure. Can you still hear me even without the mic? Or I can try a different one. Okay, let me try this one. This sounds better. And we'll also note that the Kenya Health Development Policy covering the period 2014 to 2030 prioritizes creating an enabling environment for private sector participation, including in healthcare provisioning and in healthcare financing. So there are purposeful about creating more space for private sector participation. Next slide, please. And this policy has been very successful, as we've seen from the growth. So turning to the methodology of the methodology that was used for the report, trained human rights practitioner was able to conduct 46 individual interviews, there were 47 in the end, individual interviews, and 3 focus groups across the 3 different urban informal settlements, that's in Mathare, in Mukuru, and in Dandora. The interviews were conducted in both English and Swahili and then translated and transcribed. Those were in Swahili were translated to English and transcribed, and then they were analyzed by the researcher in GI-ESCR, that's Rosella De Falco, using this qualitative software. And then we also received support from the Human Rights Clinic at the University of Miami School of Law, who did a lot of the literature review and background research that informed the findings in the report. Next slide, please. So the findings were assessed against Right to Health Impact Assessment Framework, which was published by GI-ESCR, ISA Uganda, and the University of Essex Human Rights Center Clinic. In I believe it was in 2019, these 3 institutions had come together to unpack and elaborate on the right to health framework in order to create a sort of framework to analyze the impacts. So how do we measure whether the impacts are good or bad based on the right to health framework? And so the report covers that analysis. So this framework includes elements like ensuring users are protected, effectively protected, whether they're in private facilities or in public facilities, elements like where there's donor support. The donors should also ensure that their support is going towards increasing access for everyone to access the services, and not only for people with means to access the services. Next slide, please. Okay, so I'll hand over to my colleague Rosella De Falco to share the specific findings and recommendations from the report.
Thanks, Ashina, for this wonderful introduction. Can you hear me loud and clear?
Just a moment, Rosella. We want to ensure that the people in the room can hear you. So go ahead.
Okay.
Yes, you can proceed.
Oh, okay. So first of all, apologies for not being there.
Sorry for the echo.
Yeah, there's an echo. Let's see. So there is an echo because you have to, I think you have to mute the room, and now there should be no echo. I think so. Okay, I think I can move on. So apologies for not being there, but I would be there in the next months to move forward with the advocacy surrounding the report. For now, I will introduce the findings of this report. We found 4 trends in terms of how the progressive commercialization of healthcare within the Kenya healthcare system at the level of financing, governance, and provision impacted on the right to health. And I will go through each of them. The first finding is that by focusing on investing on for-profit healthcare actors, the government gradually disinvested in public healthcare services for all. So this, of course, leads to a lack of available public services for all. As you can see, healthcare spending as a share of total government spending in Kenya is still below 14%. And as Ashina said at the beginning, this is set to decrease even more in terms of the recent developments in Kenya. And this is very concerning because Kenya committed to the Abuja Declaration, which is a declaration where African states committed to spend at least 15% of their budgets on health. So we are still below that target, and we are going even lower. In the areas that are most affected by the lack of public medical services for all are certainly the disadvantaged and marginalized areas. For instance, as you can see in this map, these are UN Habitat data from 2020. You can see that most facilities in the urban informal settlements of Mathare are private facilities, the red dots in the map. There are some NGOs, the green dots, and as of 2020, there was only one county government hospital or clinic in the settlement. We know that in the last 2 years, the situation improved. There are some more public facilities that have been built. However, this map from 2020 helps understand that individuals in these areas use for-profit healthcare a lot. And this has huge implication in terms of right to health enjoyment, as we will see later, because private facilities, especially for-profit ones, might be unsafe, might be unregulated, might be operating without a license, or providing low quality services when these services are low cost, or if they are first class looking facilities, they might be very, very expensive. And so we have other kind of problems. This lack of available public services, however, is not relevant only for individuals living in urban informal settlements, but is relevant for Kenya's population as a whole. In fact, Kenya, in terms of indicators, public health indicators to respond to the pandemic, is really short of ventilators, intensive care beds, specialists to treat COVID-19, to test for COVID-19, and to deliver the COVID-19 vaccine to the population. And also it is short of reagents for testing, oxygen tanks. So this lack of available public healthcare services is relevant for Kenya's population as a whole at all levels of income, not only for individuals in marginalized areas. Then, in terms of the second finding, we go into the area of inequalities and discrimination, barriers in accessing healthcare services. Again, here we focused on the barriers that are perceived from the people in the urban informal settlements of Dandora, Mathare, and Mukuru. A first important barrier is access to healthcare insurance. Around only 15–20%, depending on the year, of the population has any form of insurance. Those accessing to the national NHIF, the Social Healthcare Insurance Scheme of Kenya, are mostly informal workers, and those living in poverty face several barriers in accessing it, including a lack of access to a stable income to pay for the NHIF, but not only, also lack of information. Sometimes there is lack of information about the fact that the program can be very helpful, or there is lack of trust in the program Many told us that the NHIF only covers some clinics and hospitals, or only covers some part of the treatment. Maybe it covers the bed, but it doesn't cover other things such as the testing kits or the diagnostic or the drugs and medicines. So the situation is really complicated and it should be improved at many levels. Another key barrier is upfront cash payments. Many individuals in these areas, when they look for timely care that should be provided as soon as possible in order to deliver the best possible treatment to save lives and to save people from the consequences of diseases or injury, they are asked for upfront cash payments, for money, for a credit card. This shouldn't be the case. Individuals have a right to access timely healthcare when they need it. And in terms of financial obligations, that can be handled later, not before the service is granted. We also have the problem of detention of patients over unpaid medical bills, which is a severe human rights violation. We have financial barriers in accessing drugs, specialized treatment, tests and diagnostics, including for COVID-19, and including when individuals try to access healthcare at public hospitals. As we have seen, the public hospitals might be weak. They do not have sometimes enough capacity. So these individuals are then not able to receive healthcare, and they have to rely to a fragmented network of private actors and navigate this very complex system to obtain healthcare somehow, incurring in a lot of unexpected costs, completely against the WHO recommendations on financial protection in healthcare. During the COVID-19 pandemic, there were several problems, and in the report you can find them all. I want to flag that one of the problems was access to COVID-19 tests. To access a COVID-19 test at a public facility, as you might know better than me, in Kenya, it was very difficult due to long waiting lines and due, of course, to healthcare workers being overworking. So others try to access COVID-19 tests at private laboratories, but this could be very expensive and difficult to access for those living in poverty or living on a minimum wage. And the lack of access to COVID-19 tests has a lot of collateral damage on accessing other medical services and on accessing to other areas of life. So we know that having a COVID-19 test during the pandemic was a requirement to work, to participate in collective life. So many collateral damages. Another barrier was overcrowded medical facilities due to the COVID-19 pandemic. Fear of going to a medical facility either because of fear of police harassment or violating lockdown, or fear of contracting COVID-19 itself. And of course, the stigma associated with the disease. Geographical barriers in reaching facilities, information barriers. And then also there was a lot of inequality in the underlying determinants of health during the pandemic. So access to sanitation and hygiene routines, but this can be the topic for future research. And yes, here you can see a focus on barriers in accessing healthcare insurance. Several individuals told us that they use NHF, but at times they are not able to pay for the card because of lack of a steady source of income. The third finding is that the increase in the growth of private actors in healthcare in Kenya was not followed by appropriate regulation and monitoring. We found that the legal framework on regulation and monitoring in Kenya is pretty solid. However, in practice, it is not enough, not implemented well enough. Much more could be done in terms of regulation and strictly monitoring all healthcare providers, especially private healthcare providers, as the state has a human rights obligation to protect the right to health of individuals, even when when healthcare services are delivered by a third party, such as a private healthcare provider. And the outcome of lack of regulation and monitoring are episodes in which private clinics and laboratories, mostly the for-profit ones, might use expired drugs and reagents, might employ unqualified or untrained health staff. There might be episodes of malpractice, negligence, or practicing unnecessary treatments for a profit reason, or there is the problem of lack of referral to the adequate level of care because the system is so fragmented and because individual business owners are mostly focused on their own facility. So the role of the state in terms of governance will be essential to coordinate all the healthcare system. And ultimately, our finding is that of very low quality medical care. You can see in these slides what we are talking about when we talk about low cost clinics, low cost chemists. Many individuals told us that they are only left with these low-cost clinics and hospitals and chemists in their settlements. Of course, this is not in line with WHO medical and ethical standards, scientific standards on how a health facility or a chemist should look like. Individuals have the right to access the highest possible standard of physical and mental health, the highest possible in terms of modern medicine, and this is very far from those standards. I'm sorry, maybe I'm talking a bit too much. That's part of me being Italian, perhaps, but I am on my last slide, so stay with me just for these last two slides. Here, I tried to take a step back and analyze the connections between all the factors we've been discussing. And the final connection is that everything is connected. So we start with the government encouraging the for-profit sector to enter the healthcare market, because it is a market from a for-profit perspective. At the same time, the government does not invest on strengthening the existing public healthcare service that would result in better healthcare for all. What are the consequences of these policy choices that are also backed by international development actors? In fact, yesterday we presented this research at the World Bank and at the IFC, exposing the results of their development policies in countries. So what are the results of these health policy and international development policies? Socioeconomic barriers in accessing healthcare that result in individuals either renouncing to care because they get discouraged, or entering medical debt, or making something that is called in the literature catastrophic healthcare expenditure, which means when an individual enters into poverty because of seeking medical care. This situation leads to individuals on a very low income to rely on private healthcare services offering substandard medical care, unsafe medical services. And here an important disclaimer is that faith-based institutions and non-profit facilities are very important. We found very, very high quality private for-profit faith-based facilities that try to help, but they cannot substitute the government entirely as a matter of charity, no? So, of course, a very important role played by the non-profit and faith-based sector, but it is not enough to substitute a full public healthcare service. Those that can pay can travel abroad. So we have a huge phenomenon of medical tourism in Kenya. And ultimately, we have lower population health outcomes, a country that is not able to respond promptly to the pandemic in line with its international health obligation. And we have a general priority on getting a profit out of healthcare rather than focusing on health outcomes. And there is also neglect for those medical areas that do not generate a profit in the short term, such as prevention and family medicine.
Recording in progress.
And yeah, so now we are at the end of my presentation. Please, I encourage you to read our report. There are really important voices from the urban informal settlements that have to be heard, and they have to be amplified at national, regional, and international level to achieve better healthcare in Kenya. And here our policy recommendations. First policy recommendation is
Rosella?
yeah.
Hello. Sorry,
Yeah.
there was an interruption here in the room. So do you mind skipping back just to the health inequalities and healthcare access? Yes, that one. And then to the policy recommendations so that we can follow.
Yeah, so the last very important point was that overall, this system leads to neglect, prevention, and family medicine that do not generate profit in the short term, but in the long term are essential to realize the right to health. And overall, they result in a healthcare system that has lower health outcomes, and it is unable to respond to pandemic promptly. So I encourage to read our report where you have these experiences that have to be amplified at national, regional, and international level. Some of these testimonies are really telling. So I encourage you to read the report and disseminate it as much as possible. But especially, we need to achieve change. We need to change the situation. And for now, our recommendations are increase governmental funding to health in Kenya to at least 15% of the national budget to expand the availability of quality, well-coordinated public healthcare services in line with the Abuja Declaration. But so not only more money, also where this money is spent. And our recommendation is to spend it on strong public healthcare services. The private sector can play a role, but it can be a marginal role. The private sector can only fix the problems that the public sector is not able to fix. But the government has to be really the host. There has to be strong public governance, public funding, and as much public provision as possible. And the government has always to actively jump in to proactively remove barriers in accessing healthcare services. Then reverse current policies intended to encourage higher private sector engagement in healthcare, ensure that all healthcare providers are strictly regulated and monitored to ensure quality healthcare, then take concrete proactive steps to ensure universal access to social healthcare insurance or any other pre-pooled financing scheme. It is really incredible and unacceptable that such a low percentage of the population has access to social healthcare insurance. It cannot be this way. 20%, it is so low. This percentage has to become 100%. Everyone has to be insured against the risk of medical expenditure. And finally, allocate resources to high quality public healthcare services for all and stop financing market models that only benefit those that can pay, but not even them, because in the end, when market enters the logic, there is always a problem. We can see it in the US system, no? That is full of market logic. And when health becomes a commodity, we are all in danger. Health should be a right, not a commodity. Thank you. So over for the rest.
That you need to ask if the underfunding by the state is deliberate or it is by design. The underfunding health sector by the state, if it is by design or by default. At this juncture, allow me to introduce Penina. Where are you? Can you just wave and say your name and then organization? Yes. Okay. Yes.
Good morning, everyone. My name is Penina Hisa. I'm the current PHM East and Southern Africa Regional Coordinator for People's Health Movement. Thank you.
Thank you very much, Madam. David, just stand and introduce yourself there. Boss. Thank you very much. Anybody who has not introduced himself or herself? Okay. At this juncture, let us get the experiences from the community members. Ashina, in her presentation, she said that the study was actually done in Mukuru, Mathare, and Dandora, if I'm not wrong. And Mukuru is represented. Mathare, I don't know whether there's any representation from Dandora. Okay. And then we decided to bring Kibra also on board, because we know that it is also one of the biggest informal settlements we have. So we'll get 4 people, 4 in facilities, one from Kibera, Mathare, Korokosho, and Dandora. So can we start with the rep from Dandora, please? Please bring on behalf, then just come forward. Just come here. 5 minutes.
Good morning, everyone. Good morning, everyone. My name once again is Winnie Kagimbe. I come from Dandora. And I have my colleague, just wave. Yes. In issue to healthcare, Dandora, we are at mess. Those who came to do the research saw the situation that we have in Dandora. Putting in mind, we have a dumping site there where it's brings us a lot in terms of pollution, which brings TB. And we have the issue of alcohol use, drugs use, which brings more of HIV and AIDS. People who visited our areas, you saw the situation that we have there. HIV and AIDS and care, it is not taken care of. We are suffering, people are suffering there. Even if we have ARVs, they are available, but how are we taking those ARVs? Are we adhering with ARVs, and why? Poverty, yes, ignorance comes hand in hand, and to our children, they are suffering of TB, cholera, and it is overwhelming. It is overwhelming because sometimes we go to those hospitals and we don't have those drugs. And yes, it is something that it is worrying when you visit those hospitals. And the doctors, they are saying they are overwhelming. The job is too much for them. The queue, you could find the queue there. It is so long for them to handle. Like in our area, we have 5 health centers, and from morning to evening, from morning to 4, the queue is still there. So where is the problem? So we have to come up with policy that will help us through to find maybe solution to build more healthcare, and to government provide with us more doctors, more health facility, HIV, what do we call them? Support groups, because we really need them. Thank you.
Thank you very much. Mathare, speaker from Mathare, and acknowledge your colleague also. Hello. Hello. Hello.
Yes, I'm from Mathare. I have my colleague here. She will just tell you. Matter of health, we are very concerned because we are coming from informal settlement. First, there is a lot of sabotage because our doctors and health workers are the people who have put a lot of chemistry which are running without certificates, or they have given their certificates to some people who are even not qualified. So there is sabotage at some level. 2, we have a lot of need in informal settlement. 1, in health-wise, we need a support from the CSOs in the area. We congratulate the communities on coming up with the structure of CHVs and CHWs, because they are changing their name, but we know they are not being paid. The volunteers are as usual. Yeah, but they have done a lot of impact in our communities, because without them, we could have failed in health-wise. Two, the government is doing little in funding the facilities in our areas, because we need drugs. These drugs they're not coming enough, but even the little that are coming are going into private hospitals or private chemists. To mean, what is the take of this is that the sabotage of the health sector. That is the main issue in our informal settlements. Because if we could have been delivering the services as it is coming from the government, because you get that a doctor from a public hospital has a private hospital and a chemist. All medicine are going to this chemist and private hospitals. A lot of his time is not in public hospital. He's measuring much into private hospital. There is even a scenario that you can get that a doctor is absent from Monday to Friday in an hospital, but he is attending to his, or she's attending to his hospital. So the main issue is corruption and sabotage. If we can go about these two issues, I hope our health sector can be the best in the world. Another thing is about NHIF. To which standard do NHIF help the common mwananchi? Because you cannot pay monthly, and when it comes for the time of need, you need NHIF. They only pay the bed, and you pay the rest of the bill. You see that is not making sense, because a bill is 76,000, NHIF is paying 10,000, you remain with 66,000. Why were you paying NHIF? So the government should tell us, how do NHIF help us? And there is another sabotage there, because NHIF money is going to private hospitals. When you go to private hospital, they write that you are inpatient and you have been written, so there is a lot of sabotage in health sector that should be looked into. Thank you.
Thank you very much. Boss, they would remind me your name?
I'm Noah.
Noah.
Yes.
How I wish our brothers from the government and those from NHIF, we have this our sound system is having a problem, just like our health unit system. So bear with us. Trying our best. But we have really captured it right, what is happening in the health sector. And if you look at the presentation of this study, we have actually summarized it all. And we know maybe we can't blame the health professionals for indulging into the private practice, but what we need to ask is, what is the government doing to try to reduce that gap, to narrow that gap? Because if they ensure that the public hospitals are well resourced, we have enough healthcare workers, we have enough drugs, then the traffic to the private hospitals will actually minimize. So that's why I was asking, is the underfunding of the health sector by the government, is it by design or by default? Mukuru kuna Njenga na kuna yule mwingine anaitwa Nairobi, the brothers.
Hello. Kumeko sawa. Kwa majina ni Joshua Jigo, natoka upande ya Mukuru. Naweza sema kwamba the report has really captured what is happening on the ground. Yani kwa paper tofauti sana na ile kitu inafanyika on the ground. Like for example, naweza sema kwamba kiangalia article 43 venye zangu ilikuwa ameongea akasema kwamba highly attainable standard of healthcare, which is not there. Naweza sema kwamba there is inequality seriously katika mambo ya healthcare. Like for example, yes, we have hospitals. Nasema kwamba right now some were built by the NMS, but ukienda panapata kwamba it's just building like this, but there's no medicines. As well also, unaweza pata like one side we went there during this research, tukapata there was only one person. Hatukuwa tunajua kama yeye ndio nurse, hatukuwa tunajua yeye ndio nani, hatukuwa tunajua yeye one person, but building kubwa sana ile imejengwa na NMS. So you find that wanasema kwamba there are hospitals, but in real sense there's nothing like healthcare that highly attainable standard of healthcare is not there. So tunasema kwamba the report has really captured what is on the ground. Another thing when wenzangu wamesema on the issues of chemistries, we have, I can say, over 500 chemistries zile zinauza madawa, but wale wanauza ni wale not qualified. So tunasema kwa upande ya monitoring is not there completely. So maybe the government should work on monitoring. Regulation should be there. Siwe kama maybe mtu anaamka asubuhi anaenda na kufungua hospitali, anafungua chemistry anaanza kuuza madawa. We have a scenario where one child died because of a prescription and just somebody who was running one of these private chemistries. We reported that to one of our police stations, but no action was taken. Kwa sababu unapata kwamba there is that corruption part of it. So lazima kwamba okay, kwa sababu kuna lot tunaweza share maybe wakati tunadiscuss mambo ya healthcare, but kwa sababu ya time wache hapa. Asante sana.
Thank you very much. We have been looking corruption in health sector in a different perspective, but today we are getting a new perspective where the police is now also involved. They don't take action where deaths occur. The officers are responsible for the reinforcement or maybe monitoring the clinics and hospitals are not doing their work properly. We have been told that the doctors we see in Mukuru, the highest qualification they have may be as dubious as that of Sudi, but they are actually treating, and sorry for that, because that was something from the court, not from us. So we need to look at that as part of the corruption. Now, may I call upon, I don't know, is Nanu from Kibra to come and share with us what is actually happening in Kibera, the committee in reflection from Kibera. Yes. Oh, the two of you are complimenting each other, small and big. What's the biggest voice?
So, hi. So it's Nancy and Sharon here. So we want to air out our challenges, but I'd like for Sharon to start and then I'll finish because
Hello. So my name is Sharon from Kibera. and many has been said. We've tried to follow up on the challenges in Mukuru, Mathare, Dandora, and they are quite the same. Aspect of accessibility of the services in the healthcare department has been a great challenge. And in terms of the services that have been offered at the facilities, you find that there are many quack doctors around. So because we come from informal settlements, we have no option than to go to people who just open chemists and clinical dispensaries, but they're not certified or they're not legal. So we go there, but we are given medication which are not appropriate. That's why you find cases of wrong medication, wrong diagnosis, and also deaths because of such cases. Especially during the pandemic, the healthcare for patients was quite low because the main focus was dealing with casualties, patients with COVID-19. So you could find the beds were full. There were no admissions of other complications due to negligence of medical personnel. And most of them were very full of attitude as we try to compare. And in terms of affordability of the services, it's a great challenge for people who come from the slums. We don't have jobs, there's poverty. So not everyone is able to afford the expensive services because at the government facilities, you might find the services are there, but maybe you need medication, you need blood tests, x-rays, scannings that you need to be referred to other facilities. That comes with additional cost, which is quite expensive for everyone. And also, the quality of the services that we get at the facilities, it's quite wanting. So in general, we are in a mess situation, and that one tells us we have a lot to do in the health sector. Yeah, so Sharon has, said a lot, but then I'd just like to talk to us in regards to adolescent girls and young women, especially in access to healthcare facilities. Since we are talking about the slums, I know our heads are at our parents, maybe our caregivers, and how they lack money to get medicine. And yes, when they're affected, you are also very affected and you become very vulnerable. So most of the time when we seek to get services, especially when we seek to get maybe services related to sexual reproductive health and rights, or maybe something just as simple as a UTI or a yeast infection, it's very tough for girls. It's very tough for adolescent girls and young women because the hospitals, always, they never have medicine. Like, I don't know why. You go there and then they just diagnose you and then they write for you a very big list. And then they tell you, leo tumekaukiwa hatuna dawa. They send you to one chemist that maybe the doctor in the hospital is the one that owns it. So when you go there, you're given you're told you need like 1,200 to buy all the medicine. And then you just live there because you're just a girl where you're going to get all that money. And you're not even going to tell your parents that, you know what, I have a UTI and now I want you to give me 1,200. And then your dad is coming back home, jioni, na amelipwa 600 bob. You want everybody to stay hungry because you have a UTI. That is not possible. So even as we look at these issues around health, I know it's just an issue that is, that has just come out, but that is with us, but I've not had it being addressed in here. And I just want us to look at it from that perspective. This is just one example. And because of time, I believe we cannot share like everything. That is just one example. And it is a challenge for all of us, for all the girls and young women. So they cannot access these services because what is supposed to be free is not free at all. What you're supposed to get as our human right, we cannot access it. And it's because we are from marginalized communities. Maybe our parents are very poor, they cannot afford that. So you end up staying with your infection for years until it becomes worse. So even as we look at healthcare, I think it's important for us to prioritize our needs as adolescent girls and young women. Thank you so much.
Thank you, Sharon and Nancy. Thank you. Is it on? Okay, thank you, Sharon and Nancy, for adding those important perspectives. We've received a lot of information this morning regarding the impacts of private sector involvement in healthcare, and we're now going to move into a question and answer. Sorry? Oh, okay, so we have one person from Korogosho who would like to also share their perspectives. So as you come up, we are also going to have some time for a question and answer. If you have any questions on the report, if you have questions regarding the communities, you'd like more clarification, you'll have an opportunity to do so. So kindly introduce yourself and you can share your perspectives.
Okay, habari yenu. Okay, naitwa Maluki Bernard, natoka Coach FM, I'm a radio presenter and a journalist. Alafu, history ya health ni very sensitive docket. And one of the most sensitive dockets that health ni crucial sana kwa kila mtu. So from pande yetu, kuna issue ni kibao, as nimesema, but from our side kuna zile niangazie. Kuna weba unapata hiyo hakuna medicines obvious, hiyo ni kawaida for major public hospitals. Then unapata kama kuna medicine kwa public hospital unakuwa referred kwa private, unafaa uende ubuy medicine kwa chemist, ama private uende kwa private hospital. Unapata private hospital sijui wanachargingaje, they charge very expensive. Unapata like kuna this day that a kid was sick, then the mama kamrush kwa the nearest private hospital iko karibu. So vile mtu alipelekwa huko akapewa medication akachajwa like 1500, but at night mtoto akazidiwa kabisa. Ikawa tena ni story nyingine, mchukue mpeleke saa hospitali ya gava. Na ilikuwa yote ya COVID, by the way, yote kuna curfew. So kuna issue kumpeleka hospitali ya gava, kumfikisha hosi ya gava. Uzuri hiyo time tulipata medicine, akahudumiwa na tulichaji tu like 500 peke yake, na hapo mtoto akapona. So unaona kuna a lot of like in those private hospitals nafasi kuwe regulated, as in wala soko in charge wakuwe very keen about hizo hospitals nyingi huku mtaani, waziregulate vizuri. Alafu napata pia kuna hizi public hospitals, napata hata public hospital na stima, like where we broadcast radio station iko situated na compound same na hospitali ya gava. So napata there is a day kwa broadcasting saa 1 usiku. So kutoka show nikapata pregnant woman amekuja ku give birth. So ku give birth akapata, I think kuna one doctor ako pande ndani na usiku na giza, sasa hizi sema kama kuna mtu ndani ama kuna mtu ndani. So vile tukamsaidia tukanoka kufungua doctor huko, akatambia hiyo si yote ina stima. Sana shina sasa huyu sasa saidikaje hakuna stima, hiyo situation tindaje. So hiyo pia ni major challenge to sisi understand. Hospitali gava na Nairobi County haina stima aje, na mtu personal nyumba kuna stima. So pia unapata hiyo ni issue. Alafu napata pia doctors pia, as in they do not have the good relationship with patients, as in our treat vile, I don't know kama kuna certain way obvious na for treat patient, like unapata some doctors are very rude. Hata unapata patient kwamba mimi siwezi ile hosi because huko vile wanatreatiwa niko na ku abused or something like that. So those are the issues. Alafu another issue unapata NHIF unapata kuna mtu amefanywa follow up hapo ndani hapo registered ama wakilipia, lakini unapata ile tema kwa shida ataka maybe ahudumiwa mpaka hudumiwe, anaambiwa hiyo card ifanye na same emergency. Unasema nafanya tena kwa mfuko yako tena utry kusort issue because health ni important, hawezi moja tena sijui mwanze clarify hiyo NHIF. So hizo ndio issues. Alafu from our side pia kuna hospitals mpya zimejengwa na government. Like unapata hizo hospital like the recent one launchiwa like 1 month ago, but tunapata like bed per night ni almost the same amount mwananchi alipa rent yake for a whole month. So now you had a pay like 800 for one night. And then your card double like 350. No msali nyumba ya 200 na shukwa slam kabisa wala swali prokojo. So na hiyo yani na ku access health ni ngumu sana. Yeah.
Asante sana. It's very interesting how similar across all the different communities the issues are. And even if we're seeing the government making an effort, so like now they have built a few hospitals in some areas, there's still challenges within those public hospitals, and that's contributing to fueling the issues within the private side of things. So I've already seen a few hands up. Perhaps you can come this way so that the people online can hear you easily. But the first question, any other questions in the room, and then we can take questions online if there are any. All right, please, so you can start off. We'll take 3 and then respond to those. So you'll go first, and then Lavender, and then Ravi.
Okay, good morning. Maybe my name is Victor Mukuru. I've been living in Kibera for the last, I think, 25 years. I came to Kibera as around 4 years in 1989. So I know the place is very well. Now, maybe the first question before I do my observation is that maybe what criteria do you use when you are using the survey? Maybe how many people did you reach when you're doing this survey? So that's the question, maybe you'll answer later. Now, observation is that people in slums areas lack communication, just communication. Because if you ask someone, do you know about this health center? Atakwambia ajui. Unaona? Atakwambia by the way, hii ni NGO ama ni hospitali, because if you go there, iko na mambo mingi sana. Kibera, you have many things, eh? So the communication is key. Another thing, especially this during COVID-19, it was myths and misinformation everywhere. That to prepare vaccine, but one mabawa, those things. Eh? That's why we had low intake of these vaccines in the community. So we teamed up some of the journalists. We did a small survey in the area. We did some photos, and then we engaged some also dancing groups. Who are dancing. I think Mother Trust, there's a lady Benazir. Yeah, we walked around there, and then kwa kweli watu hawajui what's going on. Even this issue NHIF, most of them hata kuuliza ni pesa ngapi wanafaa kutoa per month, hawatakuambia. Unaona? And that one comes to our NGOs in Kibera, for example. Yes, NGOs are doing a good job, but not enough. How many NGOs do we have in Kibera? How many of them? Over 1,000, but only 2 or 3 known. So that's just a briefcase. NGOs, imagine over 1,000 NGOs in Kibera alone, but no information. Yani, hakuna anything we can see. No. So that's a big challenge to NGOs. Another thing, Kibera people wanapenda sasa kama kikiumana, they just come and do their own things. Like now, I did a story on sickle cell children who are living with the sickle cell disease. Walilazimika kukuja pamoja. They came together. Kids from age 7 to 19. They formed a foundation. They formed a group to help themselves. Reason, during COVID-19, the government diverted all its minds to COVID-19. Wakasahau mambo na these drugs za watoto sickle cell kama hizo. So they came together to raise their voice. Hey, government, we are here. Hey, government, we are here. Please help us. We did such a story. So in this informal settlement, there's a big problem. So it's our mandate as NGOs and media to come together. And also, please, you NGOs, you know where the problem is. Come tell media. We know how to go there and do such stories. Thank you.
Thank you. Indeed, it's important to coordinate with the media and communicate effectively. So we'll take 2 more questions from the room, from Lavender, first, and then from Ravi.
Thank you, and thank you for this invitation. I think this report is quite powerful. So I have two main, I guess, questions on the report and an observation I've made hearing my brothers and sisters speaking from the informal settlements. So on the report, health is a devolved function. And I know this report only covers Nairobi. So it would be interesting to know what other dynamics are happening in other counties. And if we can possibly get like a best practice in any county, so we can either, adopt in that case. So maybe it's something it would be nice to hear from. And then I was just, interested to know, we identify public hospitals in the report. And this is just from the policy brief. Do we, for example, try to say whether there are, the different levels? Because once we have that information, it's easier to know, let's say a level 4 hospital should have this staffing norms. So for example, the different kinds of doctors that are, meant to be in this hospital. And in that case, it would be easier to even have stronger asks to the different ministry or Ministry of Health or the county governments. So those are my two questions regarding the report. And then my observation that I've made just listening to, what's happening in the slums. It's really sad what we hear, but I just want to, to remind us about Article 1 of the Constitution, which says all sovereign power belongs to the people. You're from Mukuru, right? Mathare. If you look at the room, do you see any duty bearers here? Any people from the government? Anyone who we can vent to? Anyone from the state? No one, okay? So as much as it's their responsibility to respect and fulfill the right to health, we also can't sit back and wait for them to do it, okay? Because I believe this all sovereign power belongs to the people is really powerful. And I know that community members have in many ways, taken things to their hand. And I can give you an example of when we were dealing with communities who came and were complaining about sexual and gender-based violence in Mukuru, in Korogosho, in Kibra, and in Mathare, okay? They said, okay, we've been complaining a lot to the government, okay? But we can actually take steps. So they formed this group of gender defenders in which they can actually, go and give this advice to different girls, or, just bring in different people who can assist in this. I'm not saying that we let the government off the hook, no. What I'm saying is, what can we do as people who are really affected by this? And I want to slightly contradict my brother who spoke earlier about the responsibilities of NGOs. I'll be honest with you, NGOs and CSOs do not have solutions for communities. It's communities who have those solutions, okay? Amnesty, for example, I'm Lavender from Amnesty. I won't come and say Amnesty has solutions for what's happening with health. You're the ones who are on the ground and you know what you need, and you even know how to organize yourselves, okay? And how we come in is just to push your voice. So maybe that's just a proposal from me, an encouragement from you. I know you're very strong, you're very organized. You talked about the sickle cell organization in Kibra, and I really commend that. So I think, yeah, that's just my observation and comments. Thank you.
Thank you, Lavender. Ravi.
Hi, good morning again. Just a few quick points. And it's first, it's really to thank those of you who've come from various the communities in these reports. Hearing from you is very important. From the community media, I think that's essential. A few things I just want to mention. Number one is we have the big four, right? And now we're coming to the end of that government's term. We're looking at a new election. And what do we have to show for it? I think we have newspaper headlines, but nothing else, right? It really gets to one of the points that's come out. How are we actually making sure that good health services are available to people? And one of the recommendations we have is to look at NHIF, I think we need to question that. I don't think NHIF makes sense for Kenya. And putting it more broadly, when the next politician comes up with the next big agenda and they say UHC is going to be X, they're talking about social health insurance, which is just another way of taking money from the Wananchi pockets and putting it into their own pockets. And I don't think that's what we want to advocate for. I think we really need to change that. So let's stop talking about NHIF, except to say it should be disbanded. It's a concentration of money in the government's hands, and they don't use it well. Let's find a way to support strong quality health services from the taxes that are already collected, and not from new funds taken from individual pockets. So that's number one. Second is I'm hearing our sisters, and they talked about the doctors are rude. That's exactly what you said, right? Yeah. If we want quality health for all our people, the health workers are the most important. And here we're hearing the private sector is delivering quality health, the public sector is not. Part of it is because we're not investing, or we're not putting resources into the public sector. And part of it is another issue. We need to figure out what's going on. Is it government health services are for the poor, we look down on the poor, and therefore we treat them badly? And that culture needs to be addressed also. I very much believe in supporting our health workers, especially during the pandemic. They've really shown. But we have to also see what's going to change so that people want to go to the government health services. Because without respect and dignity, we're not going to have quality. Last point I want to raise is about, we need to just say, we need accountability here, right? It's good for us to come together. I think, look around, we have our community media, we have our community voices, we have human rights organizations like Amnesty and Kellen, we have human rights defenders. But what are we going to do to push things forward? And 2022 is a time for change in Kenya, right? We have 9th of August. Afterwards, we will have a new administration. It is guaranteed not to be the old administration. What are we going to do now to shape what they say in the months ahead and what they do from 10th of August onwards, or whenever they take office? We know there will be a delay. So let's think about that. How can we, with our human rights perspective, say this is what we want for health? And then we get to the technical issues of this is the health system, these are the health workers, this is the health financing, and this is how we want to shape the policies that will deliver the right kind of health. Are we together on that? And it's being said in other ways, but I think we need to really say we have to hold the leaders to account. Yeah, I'll stop there. Thanks so much again.
Thank you for those. All right. Thank you for those reflections, Ravi. I think before we take another round of questions, I'd just like to respond to some of the questions and comments that have been raised. The first, so there was a question on the criteria for the research, how many people we spoke with, and whether, so the idea was, in total, we spoke with about 47 individuals and then had 3 focus group discussions where we interacted with more people. And the idea was to hear from all of the different voices. So from community health workers and volunteers, from proprietors of some of the private hospitals, from staff within the public hospitals, and then from the community members themselves who interact with these health facilities. And that's how we were able to get the information. In terms of the dynamics in other counties. So yes, the research focused on Nairobi County, although within the literature review, there's some references to outside. So rural areas, for instance, also have a big challenge in terms of the public facilities being accessible in terms of distance. Many times the facilities are too far away, and then the facilities don't have all of the staff and all of the resources that are required. So a lot of this of similar challenges outside of Nairobi are prevalent. A lot of the challenges within Nairobi are prevalent outside of Nairobi as well. And in terms of a best practice, I think it's a matter of adjusting to the context, because this approach was used here, and I think there have been strengths and there have been challenges, and it's so connecting to the point that this is not a one-time discussion. It has to be an ongoing discussion. We might need to regroup and look at the process for this and how we can replicate it in other counties, because as you said, the challenges are similar, but they all urgently need to be addressed, because health is one of these things where if we drop the ball, there's a chance that there won't be an opportunity to make it up for that individual who didn't manage to access the services. The report does speak to different levels of hospitals. So we know in Kenya, the system has from level 1, 2, 3, 4, and 5, where level 1 is for a very simple primary health interventions, prevention. And then as you go up, it becomes more complex. At the level 2, level 3, for instance, you would have clinical officers and nurses. And then as you go further up, now you have more doctors being present. And then we have the tertiary institution. So it does speak to some of these dynamics in some areas in the detailed report. I like the point that sovereign power belongs to the people. I like the reminder in this discussion, because it's not to be defeatist, it's not to give up on the situation, but it's definitely for us to come together and see how we can continue to push for improvement. Questioning NHIF. I personally, I think it is high time to question NHIF and to push for a tax-based system, because as long as it's out-of-pocket payments, there are going to be people who are excluded. And if they can't afford the services and can't get the services, there's a problem there that has to be addressed. And it's high time that we push the government to start reimagining. So I think the report talks about reimagining, reconstituting our health insurance framework. Also, one of the comments raised something about the quality in private facilities being better than in public facilities. Although I think it's important to understand that the dynamic with private facilities is sort of twofold. So there are the high end, I'm not going to name them, but we know them, private facilities that are expensive, that are hard to access, and they do offer what can be termed quality services, better than public in most instances. But in informal settlements, there are mushrooming little clinics, chemists, etc., that are set up sometimes by qualified people, sometimes not by qualified people. And the quality of services in these facilities is the one that's really questioned. The monitoring and regulation in these facilities also is not effective. That's why they're able to operate. There was a story that's captured in the report that you'll see someone set up a little shack to be a health facility, carried out an abortion that went the wrong way and the patient died. And they just tore it down and moved. So it's not possible to follow up. It's not possible to hold this person accountable. And as we've heard already, the police are not providing the support that they should to ensure that in such instances, there can be justice, because justice is an important element of healthcare. We are a little over time, but I'd like to check if there are any other questions in the room. Online, I don't see any hands up, so I think we're okay. Are there any other questions or reflections in the room? And then we could give Rosella, if you have something to add, have a chance. So we'll hear from Joshua. Joshua wants to add something.
Thank you. Just one question. Why is it that in the report it is said that a lot of money from NHIF is going to the private sector and not public sector? That's my question. Thank you.
Thank you. That's a good question. From Willie.
I have a question from the government. What happened to the bill that we passed? Indicates that all CHVs are supposed to be paid 3,000 per month. I have been a CHV from 2010 and I have never received anything. So it is very demoralizing and very annoying. Thank you.
Thank you, Winnie. We'll hear from Thuku and then from Noah, and then we can do a round of responses.
Mine is a quick question. In one of the recommendations, spoke to reversal of policies that contribute towards allocation of funds towards private facilities as opposed to public facilities. So I just wanted to know, did the body of the research identify the specific policies or regulations that need to be reversed for purposes of advocacy? Thank you.
Thank you, Thuku and Noah.
Okay, just a concern. Just a concern about how health workers treat patients. It really hurts. So in the report, can you add some bit of it, because everybody is not going to the public health sectors because of how they are being mistreated. When mtu wa AIDS, tenti yenu iko huko. It is like not giving them the best they need. Yeah.
Thank you, Noah. Okay, a few more hands have gone up in the room. So I think we're done. They need to come because of the people online. Yes, so please come on up. There was a second hand. Oh, you want to? Okay. Can we put it, if you place it here, is it okay?
You know, choose both. Yes. Okay. So thank you. I just wanted to ask something to my my colleague who spoke about the AGYWs. I've just glanced quickly through the report. I've noticed there's nothing said about maternal health care and how what access has been like during COVID-19, but we know that was a significant problem. So perhaps we could understand why that gap. But more importantly, I know there's this discussion about NHIF and its appropriateness, but what about the other hand where NHIF has actually been used by pregnant women in informal settings to increase access to maternal health care? Is that accurate? And I'd like you to respond. Or somebody from the community.
Thank you. So this is the final round of, okay, and then so I'd speak about maternal health care from my perspective as I know it. I know it in relation to teen pregnancies and teen moms. And I know it is not easy for you to go to a hospital and use your NHIF. Even when you are almost delivering, it's easy for you to go to a clinic that is just close by, and then there's a hospital around where most of the teen moms stay. They go to access healthcare, but they don't take NHIF even from their parents. They do not use that. They say the government in our Sumbwa and they don't take NHIF, so you have to pay from the pocket. And if your parent does not have money, you'll have to go back to the community, go ask people to changia you, and then they pay for you. Also, I was looking, I came to ask also a question on, why is it that we are in the reports also, SRHR has not come out clearly, and how young women and girls can be able to access healthcare? Because we know very well young women and girls do not go to work and they are not able to, they do not have NHIF. So then they have to, so how do they pay for their services? And also looking at it from the parents' angle, how can we make sure that the girls or the young women are able to access these services without needing any NHIF? Is it possible that we can be able to probably reduce or maybe just add some money into the kitty or where so that girls and young women can be able to get these services at lesser fees or at a lesser cost, if that's possible. Maybe by just showing their school ID or something. And can that work? Yeah, thank you.
Okay, I can see there are people online who would like to respond and to also raise some questions. So just, you can come up and make your comment while and so I've seen Geoffrey's hand was up. I've seen that Alan, your hand was up as well. You'll just prepare to speak after Christine.
Because I'm attempting to respond, maybe I could come after they have asked the question.
No, come on up so that we can keep just because it's an ongoing discussion and they might have responses as well.
So good morning once again. I will attempt to respond to some of the concerns raised, not because I work with government, not because I work with NHIF, but because I have been privileged, quote unquote, to engage with some of these policy makers. So one, I want to throw a challenge to us. Why are health facilities in our vicinity? Because we need to use them, right? Do we own these facilities? And by owning here, I don't mean nimelipia, nimejenga, nimechangia, but how is our engagement? How is our partnership with these facilities? When we go to a health facility, for example, do they have a service charter? Do we know what that service charter is meant to do? Do we know that we can use a service charter as a tool for monitoring the quality of services that are offered? Do we have a feedback mechanism at these health facilities? For example, a service charter is supposed to give us a way of connecting to this facility. Do we have an email address? Do we have a phone number that we can reach to raise concerns that we can use to get in touch with these facilities? The other concern is, do we have the health management committees? Do we understand, do we know who they are? And do we know what they do at the health facilities? How do we engage them? Do we understand the bit that this is one angle of engagement? So maybe not to answer, but I want us to, as we have this discussion, I want us to look at some of the gaps that we might have contributed as citizens. We need to be involved. The Constitution talks about public participation. How many of us are taking advantage of those platforms? For example, when there is the call for us to participate in the budget making process, do we ever get to participate? And if we do not participate, what are some of the challenges? What is hindering us from participating so that we could understand, yes, we could understand what is stopping us from participating. And the question will therefore be, how do we participate? How do we go against these challenges? And finally, on NHIF, I also have concerns with NHIF, but NHIF has a number of packages. There is one called the Linda Mama. I don't know if you've heard about it. So the Linda Mama is for expectant women in Kenya. Whether you are a resident, whether you are a citizen, so as long as you are expectant and you are within the borders, then Linda Mama is for you. The challenge is we do not understand some of these packages. There are a number of packages offered by NHIF. Secondly, we have, is it okay? Secondly, we have the bit about the high school cover. There is a cover for high school students. Do we understand about it? High school students in public facilities. Do we understand it? Do we know that it exists? How does it operate? Sawa sawa. I see Ashina is telling me time is up. So we continue engaging. Thank you.
Thank you. Online, okay. I can see there are people who want to contribute online. So in the room, if you still have questions and reflections, or you need to respond to a question that was directed to you, please just hold on to it for a moment so we can hear from the people online. All right, so Alan, I see that your hand is up. Go ahead.
So thank you. I think Rosella and I have had an exchange in the chat. I think my concern was more, first of all, to thank everyone who's put forward the report, and from the communities, from the organizers and the partners. I think my major concern was how then do we actualize the recommendations, but Rosella has reassured me there's an advocacy plan. And as Kerlin, we look forward to seeing it and seeing what we can contribute towards making the recommendations a reality. Thank you for the opportunity to intervene. Over to you.
Thank you, Alan. Thank you also for that comment. Yes, there is a plan, and we're hoping to provide at least an overview of it as part of the conclusion to this discussion, as an entry point to carry on the conversation and carry on the collaboration. Geoffrey, your hand was also up. Go ahead. In case you're speaking, Geoffrey, we can't hear you. You don't seem muted, but your hand is up, but we can't hear you. Okay, perhaps you could type it in the chat and then we'll read it out. Were there any other reflections in the room, Dan?
Comment. Somebody asked why a bigger percentage of NHIS money is going to private facilities. I don't have an answer to that. I'm sure you have, but my added question to that for us, why is it that we have a government that trusts a private facility to take care of its civil servants? Why is it that Nairobi West Hospital is accredited for civil servants with special NHIF package to be taken care of there, instead of putting it maybe in KNH or Pagati for that matter? So these are deliberate efforts, and in sometimes back in 2020, we found out that actually 60% of NHIF money go to 3 major hospitals which are private. That is the Nairobi West Hospital, Nairobi Women, and the Nairobi Hospital. And Mwananchi, Mama Mboga, who is the major contributor to the scheme, doesn't have access to those facilities, and also doesn't have the package that is responsive to their health needs to allow them to access such facilities. So, colleagues, I hope before we leave here, we need to have a candid discussion on a way forward on how we want to engage this NHIF question before it leaves the floor of the House. We all know now every presidential candidate is talking health. We have the Baba Care proposal, and we have the other wing also bringing another promise. So as players in this space, how best can we put up together our efforts and interrogate the bill before the House, look at the potential landmines in it, interrogate the further, they already rolled out UHC and how responsive it is now, etc., etc. So the Linda Mama question that came from our friend there. If you engage with the users of Linda Mama at the community level, they will tell you, yes, it is there, but only the human resource is free. But the products and commodities that go into that, you have to buy and go with. Am I lying? You have to buy cotton, you have to buy at some point syringes and go with them there. So how free is Linda Mama? That's one question. And the NHIF also have to be clear to the public about the packages that Ajulu has mentioned are not known. What is the Mama Mboga package? What is the comprehensive package for civil servants? What is the other one that they can use to seek healthcare abroad under NHIS? What are the services in those packages? And under UHC, now that they are making NHIF mandatory for every adult, what are the benefits under NHIF to access UHC services? So those are my few comments.
Thank you, Dan. The question that we have received online from Jeffrey, I'll just read it out on his behalf. He says, it's a huge concern that we have comprehensive laws and policies on the right to health. I'm just thinking, are there gaps that inhibit the enjoyment to this right? Good report to shape advocacy and other interventions. Power belongs to the people. CSOs are part of the people. We are not duty bearers, but we are at a better place to lobby and call out the government to improve service delivery. As CSOs, we have our work cut out for us. So it's a comment from Jeffrey. Thank you very much. Indeed, we do have our work cut out for us. There is a lot that we need to do, but to bear in mind that we need to not become part of the problem, that we need to ensure that the obligation remains on the state and we don't take that away from them and we just continue to push them to do the right thing. And that as CSOs do that, they ensure that they're connected with communities, because as was shared earlier, it's communities who know what they need best. A question had been directed to Ravi. I don't know if you have a response, but in the meantime, you can come up and share some. So we'll take 2 final comments and then wrap up the discussion.
Thank you very much. And on my side, I was about NHIF and the package of Linda Mama. I had my colleague in the house was asking about if you know about the Linda Mama packages. And concerning the package and in especially the rural settlement, or the low income settlement, like in Mathare, we had a discussion where one of us was sharing with us about that Linda Mama package. And when a mother or a young woman in slum goes for that service in a public hospital and you want to enroll in that Linda Mama package, and you're being asked to give out 1,000 shillings. I realized that before it was free, but now when you go to register for it, you have to pay 1,000 shillings. And when you're being asked to pay 1,000 shillings, surely, and you yourself, you cannot even afford 200 for food, is that realistic? Huh? So I think you should consider, if it is free, let it be free. And if it is paying, let us know to what extent is it going to benefit the person. Huh?
Hi, just a quick response, and specifically on Linda Mama. It's not to say that NHIF is evil. NHIF can have some good, right? But what is the purpose of NHIF? it's not actually to make services accessible or available to the population of Kenya. Its purpose is to move money. And that's the problem we have in Kenya. Our health system is designed to move money, and you, all of us, are the excuse for moving money, but not the purpose for it. The purpose is to put it in private pockets. And that's where this report is very important, because we see that even with Linda Mama, we don't want to criticize it, right? Pregnant women are getting services at low or no cost. It used to be no cost, you're right, it's gone up. But why should there be a cost at all? Why should we have a system that's designed to take some Kidogo funds, 200, 500, now 1,000, from the pockets of people who need it, who need services, and move it to somebody else's pocket, right? We in Kenya, it's a dynamic society. Our government says we are a middle income country. There is a national treasury that can pay for this because of our hard work already. There's no reason to charge something extra. And then, as Dan pointed out, move it 60% of it to 3 private facilities. It just doesn't make sense. So it's not to say that Linda Mama is a failure or NHIF is intrinsically bad. It's intrinsically designed to move money. And we need to change that approach in Kenya, because if we're just trying to use a health system to move money, we've got it backwards. We should be moving money to make a strong health system. Yeah. All right, thanks.
Thank you, Ravi, and thank you all for your vibrant participation. I'm going to give Rosella a chance to respond to some of the questions and issues that have come up.
Hello, can you hear me?
Yes.
Okay. So
yes, we can hear you.
Okay, I wanted to quickly respond on some of the excellent questions that were made. First of all, maternal care, women, child care. That's, of course, a crucial topic, and it is in the report. So the policy brief that you have there printed, it's only a summary, but the report is a 40-page long report that explores the experience of women and mothers and their problems in accessing medical care. So I want to reassure you that the gender perspective and women perspective is fully covered in the report. And we hope actually to do more. This was a first exploratory report on a topic that few civil society organizations are working on, the problem of specifically private healthcare provision and the right to health. So this was a first exploration. Now we want to do more. And perhaps in the future, we might focus only on maternal care, for instance, or some of the other people and representatives of CSO suggested to focus on positive examples. That's also an excellent idea. In the future, we might do a policy brief or advocacy focusing on a positive example that then we can apply in other contexts, in other counties, etc. I wanted to also quickly respond on the NHIF and how it is connected to private provision. Well, between 2016 and 2020, private facilities received 82% of NHIF outpatient benefits and 64% of inpatient benefits. This means that more than a half of the funds of the NHIF has been allocated in practice to private facilities, and this is a fact. This is not to say that social healthcare insurance is bad per se. Germany has a fantastic social healthcare insurance system which covers the totality of the population. It works really well. It's not that social healthcare insurance cannot work. It can work. The alternative is a tax-based system. Both can work as long as the final outcome, as Ravi was saying, is providing services to the population, and 100% of the population. Some people discussed about Linda Mamba. Yes, of course, there are these tiny programs targeted to marginalized individuals to get some care at free or low cost, but these kind of programs designed for the poor people, which is also it creates inequality per se, not to have programs targeted only to poor people. These programs only cover tiny service packages. The goal of social healthcare insurance should be to provide a wide package of benefits, prevention, treatment, rehabilitation for all diseases to the full population, not a small part, a small percentage. No, 100%, the highest, the widest possible package. This is the kind of healthcare you have in Germany. This is the kind of healthcare you have in Belgium. This is the kind of healthcare you have in Italy. Why Kenya shouldn't have it? Also, Kenya should have a 100% population covered with a wide package. Health is not a matter of charity. It is not a privilege. It is a right of everyone. So we should stop, and we have to go out of this mentality of health as a charity. You know, you can give these tiny programs to the poor people. No, this is not the right mentality to ask for 100% coverage, wide package for everyone. And then I wanted to jump quickly in on the policies that have to be reverted. So we are a human rights organization. Our job is not to go in Kenya and tell policymakers, so you have to do this, you have to do that. We, as human rights organization, we can work with governments to help them understand what are the gaps in their policies and what are the impacts of their policies on the right to health. For instance, in the Kenya Health Development Policy 2014-2030, it is written that the government shall create an enabling environment for increased private sector participation in healthcare provision and financing, including with tax exemption and other fiscal measures. So our job as CSO, as social justice advocate, is to ask the government of Kenya, will this arrive, is this supporting the goal of having 100% people accessing healthcare for free or at low cost? This is our job. And also in the how the NHIF is designed, we have to monitor it and we have to reverse it. But especially the policies I'm talking about are the health policies by the Ministry of Health. And I hope I replied to all questions. I hope we will stay in touch.
Yes,
over.
Thank you, Rosella. Thanks for that. I think on that, we can close the discussion. I hope that there's no one who has anything pressing that they had wanted to share but hasn't been able to share. But the key point today is that it's an ongoing conversation. So as we wrap up the discussion for today, we are going to share a press statement for the benefit of the media in the house so that they have something that they can easily use to go and forward with, and then give an overview of the way forward. Yeah. So in terms of the way forward, as we've alluded to before, this is not the final step in terms of the advocacy and communication around the report. Together with the community and with PHM Kenya, as a start, the tentative intention is to engage with policymakers around this report, have a roundtable discussion with the policymakers, and then also engage with communities. So go to each of the three where the research was done at first to sensitize, because as we've heard today, communication, accurate information is a challenge. So to go and sensitize, disseminate, have discussions within the communities themselves. And the initial plan is the first three communities. And also to highlight that all of this is building up on an ongoing conversation. So last year around November, Haki Jamii launched a report on a similar theme. And they were supportive and provided a lot of input into the conceptualization of this report, because the intention is to build on what is going on, to build on the momentum already. And as much as possible, also to be able to collaborate more with everyone in this room, because it's a matter that touches on all of the work that we're doing. So we will follow up this discussion with an invitation for a more detailed discussion on the advocacy steps going forward and how to collaborate and coordinate better, which we were hoping to do today, but there were a lot of hiccups at the start that have taken up a lot of time, and we're glad that at least everything smoothed out and we've been able to have the discussion. But the time element we've missed out on. So we will reconvene and follow up on how we can work together on the advocacy. So allow me to just read out the press statement. Yes, so community participants. So we're just waiting for the community to.
Yes.
The logo. Yes, ask Priscilla. Yeah, okay. So okay, so together with community members from across the settlements in Nairobi, today the Global Initiative for Economic, Social and Cultural Rights, GI-ESCR, in partnership with the People's Health Movement Kenya, are launching a new report, Patients or Customers? The Impact of Commercialized Healthcare on the Right to Health in Kenya during the COVID-19 pandemic. This report adds to calls for the realization of the right to health for all through stronger public healthcare services and for the reversal of growing marketization of healthcare in the country. In recent years, health policies and international development actors have supported the development of market models in healthcare. As a result, between 2013 and 2021, the share of health establishments that are for-profit in Kenya grew from 33% to 43% in less than 10 years. This research report shows the consequences of these policy choices on the enjoyment of the right to health, with a focus on individuals living in urban informal settlements. The report finds 4 ways in which the privatization of healthcare has undermined the enjoyment of the right to health. First of all, for the decades of healthcare commercialization have resulted in insufficient public healthcare services. Kenya is remarkably short on medical resources that are vital to identify COVID-19 cases, for example, reagents for testing, ventilators, and ICU beds. Healthcare services are starved of resources. Healthcare spending on health was as low as 9% of the total government budget in 2020, and far below the target of 15% to which the African Union states have committed under the Abuja Declaration. Worse still, in 2020, the allocation to healthcare has further dropped to approximately 4.4% of the national budget. This is an unacceptable situation. Secondly, the commercialization has worsened inequalities in access to healthcare services. High-end private facilities are largely inaccessible to low-income households, who instead rely on the limited public medical facilities available or low-cost private health services, with many of which are offering substandard medical services. The COVID-19 pandemic further worsened the inequalities, with marginalized individuals facing geographical, information, and financial barriers in accessing COVID-19 testing and treatment, with collateral impacts on access to other medical services. As we know, if you didn't have a COVID test, you couldn't access other healthcare services as well. Thirdly, the public policies that have encouraged higher private sector engagement in healthcare over the last few decades have not been accompanied by sufficient regulation and monitoring of private healthcare actors, which has contributed to a proliferation of ramshackle private clinics, nursing homes, and laboratories. Fourthly, and connected to the above, is that several of these low-cost private facilities in marginalized areas have been found to be unsafe and offering substandard medical services. These facilities may often be run by unlicensed personnel or have chemists that are selling expired drugs, and there have been reports of episodes of misdiagnosis, unnecessary and even incorrect treatment. GI-ESCR and PHM Kenya call on the government of Kenya to strengthen public healthcare services instead of fueling market models in healthcare. In particular, the report recommends the government to increase funding to health to 15%, at least 15% of the health of the entire budget, to expand availability of quality, well-coordinated public healthcare services. Secondly, to ensure that all healthcare providers, both public and private, are strictly monitored and regulated at national, county, and local levels. Thirdly, to take concrete steps to ensure universal access to health insurance. And finally, to promote the development of a stronger public healthcare system for all. Thank you.